Hi, everybody. I'm Kevin Neal. Thanks for having me on today to talk to you about the natural history and treatment options for adolescent idiopathic scoliosis. I'm a pediatric orthopedic surgeon at Nemours in Jacksonville, Florida. I'm the section chief of pediatric orthopedics at Wolfson Children's Hospital, which is also in Jacksonville, Florida. And my academic title comes through the Mayo Clinic, where I'm an associate professor. So it's a pleasure to be with you today. So we're going to talk about adolescent idiopathic scoliosis. There are many different types of scoliosis. Idiopathic is by far the most common. There are other types like congenital scoliosis, where patients are born with abnormally shaped vertebra, and neuromuscular scoliosis, where patients have underlying conditions that affect the growth of their spine. But idiopathic is by far the most common. And idiopathic, of course, means we don't know exactly what causes it. So idiopathic scoliosis comes in different flavors. So you can get it when you're very young, before age 3. That's called infantile idiopathic scoliosis. You can get it before age 10, and that's called juvenile idiopathic scoliosis. Or you can get it when you're 10 or above, and that's called adolescent idiopathic scoliosis, or AIS. And that is by far the most common type. So we're going to be focusing on the natural history and the treatment of the most common type, adolescent idiopathic scoliosis. So how many adolescents get scoliosis? Well, we still get those numbers mostly from this classic study from Montreal and a few others. This study was done just looking at an entire population, 12 to 14-year-old boys and girls who are in grades 7 and 8. There were almost 30,000 school screenings, and over 1,000 cases of AIS were identified. So from that and a few other sources, we know that the incidence of scoliosis, or a curve greater than 10 degrees, is fairly common. It's about 1 out of 50. Larger curves become less common. So curves greater than 20 degrees are about 1 out of 250, and curves greater than 30 degrees are about 1 in 500. And then if you get to the really large curves, like the ones that we want to do surgery on, like curves greater than 50 degrees, they're much less common, like 1 out of 1,000. And so what does that mean? That means that about 95% of patients who get a diagnosis of scoliosis are not going to have curves that are ever going to be big enough to have surgery. So is there a genetic component? Almost certainly. So we know that scoliosis runs in families, and you can see here a list of some genes that have been associated with scoliosis. It's probably many more than this. It may be hundreds of genes, and we just don't understand it yet. So it's a polygenic condition, and we call that type of condition, where we just don't understand it yet, but we know it runs in families, autosomal dominant with incomplete penetrance. But we still can't tell exactly who's going to get it, even if it runs in the family. We don't know who in the family is going to have it at all, or have a small curve, or have a large curve. And we certainly can't tell what the risk of progression is just from the family history. So there are 4 factors that are associated with progression in scoliosis, and they are gender, curve location, curve size, and growth remaining. By far, the most 2 important factors are the curve size and the growth remaining. So let's go through those. So looking at the curve magnitude and growth remaining, this classic study by Lonstein in Minnesota showed us the basic pattern, which is that when we have a very young age or younger age, and we have a smaller curve, we're not at very much risk of progression. I'm sorry, when we have an older age and a very small curve, you're not at much risk for progression. So here in Lonstein's study, they're looking at Risser sign versus the size of curve. And we're going to talk a little bit later about Risser sign if you don't know what that is, but it's a maturity marker looking at the pelvis. And so patients that look mature and they have small curves have a very low risk of progression. Contrast that to patients who look immature and have larger curves, and they have a very high risk of progression. Same study looked at this with chronologic age instead of the Risser sign. And so you can see here that when patients are older and have smaller curves, they have a very low risk of progression. And younger patients with larger curves have a very high risk of progression. This pattern is going to repeat in other studies. So what if we eliminate growth remaining? What happens when patients are already mature? curve size is still a factor. So here from Stu Weinstein's natural history studies from Iowa, we see on the x-axis the curve size when patients had reached skeletal maturity. And then on the y-axis, we see the curve size many years later. In a lot of cases, these were visits 40 years later. So this is the natural history of untreated scoliosis. What happens? And so the thoracic curves are on the left, and the lumbar curves are on the right. And what we see is a cohort of patients in the bottom left corner that kind of stay on the line. And that means that their curves were non-progressive. But when we get to the larger curves, we see these cohorts of patients where the dots are all above the line. So the larger your curve is, the more likely it is to progress even after skeletal maturity. So since growth remaining and curve size are so important, let's understand how to measure growth remaining. There are a lot of different ways to do that. So one of them is just how old are you, chronologic age. The problem is it's often inaccurate. So some people are early bloomers and some people are late bloomers. For girls, we can look at menarche. The problem is that peak growth, when the spine is getting longer and patients are at most risk of scoliosis progression, actually happens 6 to 12 months before menarche. So by the time girls reach menarche, the cat's already out of the bag and they've already had their peak growth. You could look at secondary sexual characteristics. The problem with those is they're a little bit subjective, and at least in the United States, they're often not part of a routine orthopedic clinical visit. So we're not asking teenage girls to undress routinely to measure this sort of thing. We can look at serial height measurements. These are really good, actually. The only downside with serial height measurements is you need multiple visits. So this is a graph of height velocity, and you can see the basic pattern where children are growing fairly steadily through the grade school years, and then they hit a growth spurt in early adolescence, and then they slow down and stop. And you can see dots here measuring the peak height velocity. But the problem is you can't do this at the first visit because you need multiple data points to create those dots. And then there are the radiographic markers that help us measure growth remaining. And there are many of them. So the Risser sign that we talked about before and the triradiate cartilage, those are visible in the pelvis. Sanders is the left hand for bone age system that has become very popular. And there are many others. You can measure growth based on patients' open physes in almost any joint. So the proximal humerus has become very popular because you can usually see it on a PA scoliosis x-ray, for example. On the left here, we see a very young pelvis. We see open triradiate cartilages on both sides. So we know that this patient is very young and has a lot of growth remaining. This is a depiction of the Risser sign. It's a little bit different in Europe, but in the United States, what we do is we divide the ilium into 4 quadrants, and then we watch the ossification of the iliac apophysis, which in a perfect world starts laterally in the first quadrant and then progresses medially through all 4 quadrants. So if we look at the Risser sign depicted here on the left, it's gotten through 2, but really hasn't gotten much through 3. So we would probably say that this patient is a Risser 2. Once you get complete fusion of the iliac apophysis, then that's called a Risser 5, which is what we see here on the right. And then this picture is just a good example of a patient who is Risser 4. So we see iliac ossification all the way through 4 quadrants, but we can still see the apophysis. It's not completely fused yet. So this is a Risser 4 and not a Risser 5. Let's look at the Sanders system. This is based on a previous system called Tanner Whitehouse Radius Ulna Carpal Bones, or RUC. And this is a simplification of that system that was developed by Jim Sanders and published in 2018. So we're looking at the physes in the fingers and the wrist. And so what you can see here for Risser 1 is that the epiphyses, the small part at the end of the long bones, is very small in the Sanders 1. It's not as wide as the metaphyses. For a Sanders 2, we see that the epiphysis is still small, but it's gotten a little bit bigger, and it is now as wide as the metaphyses. All of the physes and all of the phalanges remain open. For Sanders 3, all of the physes and all of the phalanges remain open, but now that epiphysis has started to curl up around the corners of the metaphysis, forming little horns, or what we like to call caps. So we call this capping. And then Sanders 3 can be broken down even further into 3A and 3B. So in 3A, we see the capping, but all of the physes are open, but we do not see the capping in the distal radius. And in 3B, we start to see that little cap form on the edge of the distal radius as well. It gets a little bit easier with Sanders 4. In Sanders 4, everything's open except we start to see partial closure of the distal phalanges only. For Sanders 5, we see complete closure of the distal phalanges, but all the other physes remain open. For Sanders 6, the distal physes are completely closed, and we start to see partial closure of the middle and proximal phalanges. And then for Sanders 7, all of the physes in the fingers are completely closed, but the distal radius is still open. 7 has another subcomponent called 7B. And so in a 7B, everything is closed except the distal radius remains open, and we start to see partial closure of the distal ulna. When all of the physes in the fingers and the wrist are completely closed, then that is a Sanders 8, and growth is definitely concluded. So we want to understand the relationship of peak height velocity to these markers of growth. So peak height velocity is very important. So that is when patients are growing their fastest. This is the adolescent growth spurt, and this is the point at which patients are most at risk for scoliosis progression. So looking at some of those markers that we talked about, we can see here that Sanders 3 correlates to the upslope of peak height velocity. We can see that the triradiates close just after the peak of height velocity. Sanders 4 is the downslope. Patients are still growing fast, but not as fast as they were. Then we see menarche actually happens after peak height velocity is complete. So we talked about that before. Again, once girls reach menarche, the cat is out of the bag. Their peak growth has already finished. And then look where Risser 1 is. So the iliac apophysis doesn't begin to ossify at all until you're well past peak height velocity. So Jim Sanders looked at all of these factors to decide which ones correlated the best with peak height velocity. So which would be the best to use for measuring growth remaining. And so the best score was for the Tanner-Whitehouse system, which he converted into the simplified system that we now call the Sanders classification. Chronologic age was not bad, but look at where Risser is. Risser is way down on the list. There are a lot of things that are better at correlating with remaining growth than Risser. So most scoliosis surgeons in the United States have gravitated toward using the left hand for bone age in the Sanders system. So through regression analysis, Dr. Sanders was able to give us this predictive model for scoliosis progression. And this is going to look very similar to the studies that we saw earlier from Launstein and Weinstein. So we notice here on the vertical axis is curve size, and on the horizontal axis is the Sanders score. And we see the same pattern. So when we have larger curves and when we have younger patients, we're going to have a very high risk of progression. So you see a lot of 100% risks of progression in that box. And then when we have smaller curves and more mature patients, we have very low risk of progression. You're going to see a lot of zero risk of progression in those boxes. So this was a very good study. The only knock is that it was done using only 22 girls who were measured every 6 months until they reached skeletal maturity, and it was only done in certain types of scoliosis curves. And you can see when you dig into the confidence intervals that many of them are very wide. So a confidence interval of 0 to 100% really doesn't tell us much about an actual risk of progression. But having said that, this work has been replicated So this study from Satula and colleagues used similar methodology, but they used boys and girls instead of just girls, and they used all curve types. And they basically found a similar pattern where in the bottom left of the chart, you're seeing very high risk of progression, and in the top right of the chart, you're seeing very low risk of progression. This was a similar effort from my own institution. What we wanted to do was to reproduce Sanders' methodology using many more patients. So we had over 300 patients instead of 22, and we did boys and girls. And we looked at different curve endpoints because we thought it might be important to understand when a patient is going to progress to 35 degrees in addition to when they might progress to 50 degrees. Dr. Sanders had only looked at progression to 50 degrees. And so we did a similar regression analysis, and you can see that our data looks a little bit more granular, and that our confidence intervals are not as wide. And we were able to use this data to create a calculator. And you can go online and access this if you want to. It's available to the public. That's at apps.nemours.org/scoliosis calculator. And you can input, if you know it, the patient's curve size and their Sanders score, and it will give you their risk of progression of their scoliosis. So now that we know about the risk of progression of scoliosis, what are our options for treatment? So for very small curves, we can observe patients, of course. For more moderate curves, we can use braces. And then for larger curves, unfortunately, our only option becomes surgical intervention. So when do we brace? Well, this is the criteria that was developed by the Scoliosis Research Society a couple decades ago. This criteria was really developed to tell us who to include in research studies. It was not specifically developed to tell us who to brace, but it's kind of trended in that direction as a proxy for when we should use braces. So the optimal inclusion criteria for brace studies is patients who are 10 years old or older. So these are adolescent idiopathic scoliosis, who are RISR 0 to 2, who are therefore more skeletally immature, and whose curves are about 25 to 40 degrees and who have not had prior treatment. For girls, we also add that they should be 1 year or less post-menarchal, therefore still growing. So there are some other guidelines available. This is on the SRS website, and it has the same basic pattern, although the numbers can be just a little bit different. So but the same pattern remains. So younger patients who are still growing with moderate curves, that's who we want to do braces on. So looking at bracing, we know that they work for some people, but not for all people. So this classic study used temperature sensors in braces to look at whether time in the brace correlates with success. And it turns out that it does. So you can see the dark shaded bars are the non-progression, and the lightly shaded bars are the progressive scoliosis. And we can see that patients that wear their braces for more hours per day, as documented by temperature sensors in the braces, have less risk of progression of scoliosis. So that's great. It's still not perfect. So Dr. Sanders again looked at that same data, and he calculated the number needed to treat for bracing. So the number needed to treat is the number of people that we recommend a treatment to, divided by the number of patients where the treatment actually changes the natural history. And so he found that the number needed to treat for scoliosis braces was 3, which is actually not a bad number. That's a pretty low number needed to treat. So what does the number needed to treat for scoliosis really mean? Well, it means that we have 3 patients who have similar characteristics in terms of growth remaining in curve size. And so we're going to prescribe a brace. For one of the patients, the curve doesn't progress, but it turns out it wasn't going to progress anyway, so the brace didn't really change anything. For one patient, the curve progresses even though the patient is trying and wearing the brace, and so the brace didn't really help. And for one patient, they wear the brace and the curve doesn't progress, and it was going to progress had they not worn the brace. So that is the success patient, and that is the 1 out of 3 patients for the number needed to treat. This was also looked at in the so-called braced study. So the braced study is currently our best evidence for bracing in idiopathic scoliosis. This was a randomized controlled trial. Initially, they had to back down to a patient-directed treatment methodology because it was difficult to randomize patients to a no treatment group. But still, they were able to look at braces using temperature sensors versus an untreated control group. So it's one of the very few bracing studies that has both compliance data and a control group. And they had a very dramatic result. So they found that the braces were working, so they stopped the study early for ethical reasons. But their rate of treatment success was 72% for bracing, as compared with 48% after observation. So that's non-progression, 72% versus 48%. And they also noted with the temperature sensors that there was a positive correlation in the number of hours of brace wear and the treatment success. So they calculated a number needed to treat that was very similar to this data in the other study. Theirs was a little bit higher than 3, kind of between 3 and 4, but very similar. And so again, you see kind of similar things. So 1 out of 4 definitely successful, 2 out of 4 probably wouldn't have worsened anyway, and 1 out of 4 the curve progressed anyway. So when do we operate on patients? And to understand when to operate on patients, we need to understand the natural history of scoliosis, meaning what's the downside of non-operating. And so we get that data primarily from Dr. Weinstein's 50-year follow-up of scoliosis patients in Iowa. It turns out that patients who have untreated scoliosis are not doing as bad as you would think. So the survival compared to patients without scoliosis is the same. It does not lead to early death. There is a slight increase of risk of shortness of breath, but only associated with very large scoliosis, Cobb angle greater than 80, for example. There is a slight increase in back pain as the curves get larger, but it's not debilitating back pain. So most of it is only a little bit or moderate back pain. So patients can live with untreated scoliosis. So their conclusion was that patients remain productive and functional at a high level, and untreated scoliosis causes little physical impairment other than some back pain and some cosmetic concerns. Well, so we looked at this chart before about what happens to patients' scoliosis after skeletal maturity. And we said that there was, a pretty obvious group of people whose curves were going to progress after skeletal maturity. The red vertical line here is 50 degrees. So once your curve is past 50 degrees, it's pretty obvious that most of those patients are going to progress into adulthood. So that has kind of been a traditional number for us to start recommending surgical intervention for patients who don't want their curves to continue to progress. But if you dig into this chart a little bit more, what you'll notice is that if we draw a vertical line at about 35 degrees, there are still some patients in between 35 and 50 where the curve looks like it is progressive. There just weren't very many of them. That's why we focused on this cohort above 50 degrees. But there is now good evidence that that number may be quite a bit lower, and progression after maturity may really start in the 30s rather than at 50. So what's the bottom line on when to operate on patients? So it's not going to cause an early death. It actually doesn't really cause medical problems, maybe a little back pain, maybe some concerns about the cosmesis of the back as the bump on the back from the scoliosis increases. So it's an elective surgery. And what that means is that we offer the surgery to patients when the curve is large enough that there is substantial risk for progression after maturity, and when the patient is displeased with their current situation, when they don't like the way their back looks or feels, and they don't want it to get worse, then it's acceptable to offer scoliosis surgery. So in summary, progressive scoliosis is relatively uncommon. Curve size and growth remaining are the main factors that predict progression. Sanders is the most accurate way to predict curve progression. Observation for smaller curves and more mature patients, braces for moderate curves in growing patients only, and surgery for larger curves that may continue to progress. So thank you very much. My contact information is here. If anyone has any questions, please feel free.